Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
You know, if you've ever had a CT scan that needed contrast, you've definitely been asked those standard screening questions. But what if I told you one of the most common questions, one we've been asking for decades, is actually based on a complete myth? Well, today we're diving into a landmark new guideline that is totally shaking up how we think about contrast allergies.
You've heard this one, right? Are you allergic to iodine or shellfish? It's the question that kicks the whole thing off. For years and years, it's been a routine part of the checklist in radiology departments all over the world. And it feels safe, it feels familiar, but the entire idea behind it, it's just not right.
That's right. It's a myth. And in this first part, we're going to completely take apart this long-held and frankly incorrect belief. We're going to look at what the real science says about what's actually causing these reactions.
Okay, so let's get this perfectly straight, because we're talking about two completely different things. Think of it like apples and oranges. A real shellfish allergy? That's your immune system reacting to a specific protein called tropomyosin. But a reaction to contrast dye? That has absolutely nothing to do with the iodine atoms attached to it. It's the overall size, shape, and chemical properties of the entire contrast molecule that can cause a problem. These are two totally separate biological pathways.
And here it is, the core message from the new guidelines, stated as clearly as possible. Iodine is not an allergen. I mean, think about it. Iodine is an essential element our bodies literally need to function. It's in the salt on your dinner table. So the idea that you can be allergic to a fundamental chemical element, well, it's just a basic misunderstanding of how allergies work.
So the big question is, if it's not the iodine, what in the world is happening when someone has a bad reaction to a contrast scan? You know, understanding the real cause here is absolutely critical to managing the risk the right way.
Here's the most important thing to get. Most of what we've been calling contrast allergies aren't actually true allergies at all. In scientific terms, they're non-IgE mediated. What that means in plain English is that the contrast molecule itself can just directly, well, poke your mast cells, irritating them and causing them to release histamine. That's what gives you hives or flushing. It's a direct chemical effect, not your immune system mounting a full-scale attack. Now, can true classic allergies to contrast happen? Yes, they can, but they are much, much less common.
Okay, so picture this. A patient has a severe reaction right after getting contrast. In that moment, there's a huge clinical challenge. Is this the real deal, life-threatening anaphylaxis? Or could it be something else that can look almost identical, like a vasovagal reaction? And telling them apart is beyond crucial, because how you treat them is completely different. With a vasovagal reaction, the patient often looks pale, they're clammy, and this is key, their heart rate is slow. With anaphylaxis, you're looking for hives, flushing, and a fast racing heart rate. Making that distinction in seconds is vital, because one requires just laying the patient down and raising their legs, while the other needs an immediate shot of epinephrine. Get it wrong, and the consequences can be serious.
So where is all this new information coming from? You know, this isn't just a handful of doctors deciding to change things up. This is all based on a major new publication that's really set to become the new standard of care for everyone.
And here it is, a huge 2025 joint statement from two of the heaviest hitters in medicine, the American College of Radiology and the American Academy of Allergy, Asthma, and Immunology. Look, when the people who manage the scans and the people who are the experts on allergies get together and agree on something this big, it is absolutely time for all of us to sit up and pay attention.
Now, part of the reason we can even have this conversation is because the contrast agents themselves have gotten so much better. We've moved away from the older, clunkier agents to these newer, what we call low osmolality contrast media, or LOCM. This one change has been a total game changer, causing the rate of reactions to plummet to well under 1%. They're just so much safer and easier for the body to handle.
All right, let's get practical. Let's get into the new playbook. How do we actually handle patients who've had a reaction before? Well, these new guidelines give us a really clear step-by-step approach based on how severe that last reaction was.
So let's start with someone who had a mild reaction last time. We're talking maybe a few hives, nothing major. Here's the first huge shift. Giving them steroids beforehand, what we call pre-medication, is no longer recommended. The side effects and the delays it causes just aren't worth it. Instead, the #1 strategy is simple. Just use a different kind of contrast agent this time.
Okay, what about a moderate reaction? Let's say widespread hives or some wheezing. The top recommendation is exactly the same: switch the agent. But what about pre-medication? Well, it's not automatic anymore. It now becomes a conversation between the doctor and the patient, a shared decision where you weigh the pros and cons for that person's specific situation.
Now, for someone who had a truly severe, life-threatening reaction, the playbook gets much more cautious, as it should. Step 1, we stop and ask, do we even need contrast? Could an MRI or an ultrasound give us the answer instead? If contrast is the only way, then step 2 is yes, we pre-medicate. Step 3, we also switch the contrast agent. And finally, step 4, this has to happen in a hospital, where a full emergency team is ready to act instantly if anything goes wrong.
So, why all this focus on just switching agents? Well, the data is just incredibly clear. Get this, if you give a patient the same contrast they reacted to before, their chance of reacting again is about 1 in 4, or 25%. But if you just switch to a different agent, that risk plummets to just 6%, and that's without any pre-medication. It's just a way smarter, more effective strategy.
And to bring this all right back to where we started, the guidelines spell it out in black and white. No pre-medication is needed just because a patient says they have a shellfish allergy or an iodine allergy. That link has been officially and authoritatively busted. Just think about it. This one recommendation is going to stop thousands of people from getting unnecessary steroids and having their diagnosis delayed.
So, let's bring it all home. What are the real-world impacts of this? What are the big takeaways for you, for patients, and for healthcare providers?
All right, here's the bottom line. This new playbook means safer care because we're not giving people powerful drugs they don't actually need. It's a smarter strategy because we're prioritizing something that works better, switching the agent. It means fewer delays in getting people the scans they need to find out what's wrong. And finally, it puts a huge spotlight on something critical: better record keeping. It's not good enough to just write allergic to contrast. We need to know which one caused the problem so we can pick a different one next time.
And that really brings us to our final question for you. After everything we've just gone over, if your medical chart has iodine allergy written on it because of this old myth, maybe it's time to have a chat with your doctor. Because correcting that record isn't just about being right. It's about making sure you get the safest, smartest, and fastest care possible the next time you really need it.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.